This is Dr. Hessel recording the podcast on preoperative airway evaluation. These are the reading assignments you've been given. I recommend this particular review that was published in Evidence-Based Practice of Anesthesia. I've also submitted an expanded version of this podcast, which includes supplemental slides on Wiki and also a bibliography. These are two key papers that you need to be familiar with. I think you've already talked about them previously. The practice guidelines for difficult airways. These are the items I'm going to discuss. Competence of airway management is an essential characteristic of anesthesiologists, and we're going to highlight today item number 2. Difficulties with or failed airway are major causes of anesthesia, morbidity, and mortality. Difficult or failed airways account for about 2% of anesthesia-related mortality. The latest practice guidelines gave their definition of difficult airway and suggested various descriptors. These are some of the types of difficulties, ranging from difficult mask ventilation to difficult surgical airways and everything in between. Let me now review the incidence of these various difficult airway problems. The incidence is influenced by operator experience as well as patient factors and other circumstances. From this review article, they highlight the incidence of difficult mask ventilation, impossible mask ventilation, difficult intubation, and difficult laryngoscopy. Difficult laryngoscopy is sometimes defined as Comac-Lahun grade 3 or 4 and occurs in somewhere between 1 and 13% of patients. Difficult video laryngoscope was studied in this prospective center and found that it failed in 2% of the time when used as a primary technique, 4% when one anticipated a difficult airway, and 6% when used after failed direct laryngoscopy. So it's not always the solution to this problem. Difficult mask ventilation has various definitions, and thus the incidence varies between about 1 in 1,000 and 5 in 100. This is a 4-point scale designed to describe difficult mask ventilation. Grade 2 when grade 1 when it's easy, grade 2 when you need an oral airway or some kind of adjunct, grade 3 when it was difficult, requiring 2 providers with or without muscle relaxant, and grade 4 when you were unable to mask ventilate with these adjuncts. These are the incidences of difficult mask ventilation in various reports. In this multi-center study, they found difficult mask ventilation in about 2% of patients, difficult laryngoscopy in about 4%, and difficult, both of these present in about 0.4%. Difficult endotracheal intubation has been defined by the ASA as requiring more than 3 attempts or more than 10 minutes with an incidence of somewhere between 1 and 4%. A failed intubation, according to Benyamoff, occurs in somewhere between 0.05 and 0.4%. In their review article, Gardich and Herbert found an incidence of about 1 in 22,000 patients in surgery and about 1 in 500 patients in OB. The most dreaded situation of cannot intubate and cannot ventilate has been estimated at about between 2 in 10,000 and 1 in a million. Now let's turn to predicting difficult airway problems, and it turns out we're not very good. In this prospective study from Danish anesthesia database, they found that when difficult mass ventilation was anticipated, it was in fact only difficult in about a quarter of the patients. When mass ventilation was difficult, it had not been anticipated in over 90%. Conversely, when difficult intubation was anticipated, it was in fact difficult in only about 25%, with a false positive rate of 75. On the other hand, when intubation was difficult, it had not been anticipated in over 90% of cases. So let's talk about assessment of the airway. And this nice review article by Rosenblatt I strongly recommend to you. He indicated there were a number of issues to be considered when planning airway management, including, do you need airway management? Will direct laryngoscopy be straightforward? Can a supralaryngeal ventilation be used? Is there aspiration risk? And if you have airway failure, will the patient tolerate a period of apnea? He indicated that the ability to visualize the larynx depended on alignment, and that the sniffing position improved this, but not to 180 degrees, and the rest of the alignment requires displacing the tongue, and this depends on the size of the tongue and the mandibular space. The Mallampati classification basically evaluates the size of the tongue, while the thyromental or sternomental distances are more predictive of the mandibular space. Thus, the Mallampati score is more predictive if you have a short thyromental distance. This just illustrates the importance of Atlanto-occipital extension. Maximal extension is about 35 degrees, and this has two favorable consequences. One is increasing the mouth opening, and the second is giving optimal alignment of the larynx. And this just illustrates how one might estimate the degree of Atlanto-occipital extension. Assessment of the airway starts with history of prior difficulties, review of prior anesthetic records, physical examination, and then special studies. Does documentation of a history of previous difficult intubations predict subsequent outcome? This was investigated by another Danish study. They reviewed the Danish anesthesia database of patients who had repeat general anesthesia with an attempt at intubation. 68% had evidence of difficult tracheal intubation in the past, and 24% had evidence of failed intubation in the past. I should say 0.24% and 0.68%. In patients who had a history of prior difficult intubation, only 25% had difficulty on the follow-up. Conversely, of the patients who did not have a history of prior difficult intubation, 5% of them had a difficult intubation at the repeat. Therefore, the past history is not totally reliable. This is from Barash and indicates conditions that may have airway implications. either by causing a difficult airway or increased risk of aspiration. These are some of the syndromes that Barash has identified that are associated with difficult airway management. The components of the preoperative airway examination are well known by you and summarized in this list, mainly coming from the ASA difficult airway texts. These include the length of the upper incisors, etc., as summarized on this slide. This is another summary of some of the common airway indices that are used to assess likelihood of difficult airway. This is another summary of these features and their management implications from Barash. This is a nice chapter in a previous edition of Chestnut written by Benyamoff, in which he's identified criteria based on the pre-op airway examination. And this is a similar list from Stolting and Miller's 5th edition, indicating non-reassuring findings on the airway examination. And finally, this review published in the journal Lung. So what are some of the factors associated with a difficult airway? Objective data are hard to come by, partly because of variable definitions of a difficult airway. We've already mentioned that there are different types of difficulties, and predictors can be either single parameters or multi-factors, and we are going to review these now. Prior to this discussion of predictors, I think it's important for you to review statistical measures of predictions. These include the concept of sensitivity and specificity as summarized on this slide, the concept of false negative and false positive, and the concept of positive predictive value and negative predictive value. Recently, there's been great interest in using receiver-operator characteristic curves to judge how reliable a method is. When this curve is a diagonal going from the left lower border to the right upper border, the test is no better than chance. The more the curve occupies the left upper quadrant, the better the curve is. And this is expressed by the area under this curve. When the area is 0.5, it's no better than chance. When the error is 1, it's a perfect test. So let's turn to the issue of predicting a difficult mass ventilation. There have been a number of papers written on this. This is a summary from Barash. And this is a nice paper from Anesthesiology defining the relationship between difficult mass ventilation and difficult intubation. They found that when mass ventilation was grade 3 or 4, that it was associated with difficult intubation, but not 100%. So the two aren't closely related. This was a paper in which they investigated the incidence and risk factors for difficult mass ventilation. They used this criteria, or they qualified the difficulty of mass ventilation from easy to impossible. And you see about 17% it was considered awkward, 8% difficult, and none in this study were impossible. And these is a summary of the risk factors that they found that were associated with difficult mask ventilation, including Mallampati, class, gender, history of snoring, age, and weight. This is another review listing what they thought were risk factors for difficult mask ventilation. This was a single study of predicting impossible mask ventilation. You see the incidence, class 4, was only about 0.15%. This shows the outcome of those in which it was impossible to do mask ventilation. The good news is that they had no patient loss. These are the risk factors they found that predicted impossible mask ventilation. Another concern is predicting difficult supraglottic airway. We tend to think a supraglottic airway is a perfect solution to all of our problems, but it's not always possible. In a previous study that I mentioned previously, they did have a number of cases where supraglottic airway was unsatisfactory, and these were some of the risk factors that they found predicted that. Abnormal neck anatomy, thick neck, small thyromental distance, limited cervical motion, and limited experience of the operator. Next, the issue of predicting difficult intubation. Rosenblatt in Barash's textbook suggested this is often used synonymously with difficult DL. However, perhaps this definition is outmoded with the development and use of video laryngoscopes. He mentioned that before defining something as a difficult laryngoscopy, you need to have ideal conditions. It need to be done by an experienced practitioner. There need to be full muscle relaxation, optimal sniffing position, and proper laryngoscope and use of laryngeal manipulation. Some of the factors associated with difficult laryngoscopy and difficult intubation are hard to come by, but as I said, a common definition is poor Comac-Lehun view of the larynx. This is an illustration of the original Comac-Lehun grading scale of 1 through 4. This is another illustration of it, and these are actual diagrams showing the 4 characteristics. These original classification have been modified. The first was by Yentis, and he divided class 2 into A and B. Class 2A was when you saw some but not all of the larynx, vocal cords I should say, and class 2B was when you did not see any of the vocal cords but did see the aryepiglottic folds. Cook then modified class 3 into those in which the epiglottis was visible but could be lifted, and class 3B when the epiglottis was visible but could not be lifted. This shows the likelihood of the ability to intubate based on this classification. If they're class 1 and 2A, it should be easy most of the time. If it's class 2B and 3A, they likely will require some use of a gum bougie, and if they're class 3B or 4, about 75% will be difficult and will require adjuncts. On the other hand, a poor view doesn't always imply a difficult intubation, and as you see in this review or study by Eberhardt of the patients who had class 3 or 4 CL views, that was 12% of their patients, nearly half were intubated on first attempt, and about 85% were intubated after repeat attempts, and only 15% required an alternate approach. Unfortunately, they had no morbidity or mortality. These are some of the anatomic conditions associated with difficult, rigid laryngoscopy. And this is another listing by review article. The point, of course, is that we are trying to get a good view of the larynx here. And to do this, you first have to have optimal Atlanto-occipital extension, but then you have to be able to pull the tongue out of the way in order to see the larynx. Now, in this excellent review article that I mentioned to you at the start of this podcast, he evaluated various single predictors as listed on this slide. And you can find more details on the supplemental slides that I've posted in Wiki. What they found was that no test has adequate sensitivity without substantial false positives. They have a low sensitivity and positive predictive value, a specificity of somewhere between 30 and 70%. And again, this is in their table that I posted on Wiki. These are some other assessments of the sensitivity and specificity of single parameters. And yet another review of the sensitivity and specificity of common physical indices of airway evaluation. One commonly used one is the Mallampati classification. This must be done with the patient sitting up, sticking their tongue out, but not phonating. And these are another illustration of the various Mallampati classes. As I say, the Mallampati class mainly reflects the size of the tongue and the space in the mouth. Some have added a fourth class, so-called class 0, when you can see the tip of the epiglottis. And some have added phonation and neck extension to the performance of the Mallampati evaluation. Although phonation has not been found to improve it, but neck extension does make it less sensitive but more specific. And yet some other photographs of the Mallampati classification. In the review article I've mentioned several times, they found the sensitivity to be between 60 and 80%, the specificity between 50 and 80%, and the positive predictive value very poor at only about 20%. I have included a number of other papers in my supplemental slides that I posted on Wiki. This is a receiver operator curve of the Mallampati classification to predict difficult airway, and you see the area under the curve is about 75%. So it's halfway between perfect and no better than a toss of a coin. As we mentioned, craniocervical extension improves the specificity and predictive value of the Mallampati, as summarized in this study. Another helpful test is the upper lip bite test. This was described by Dr. Kahn, and this is the classification. Class 1, if the lower incisors can cover the vermilion line. Class 2, if it can touch the upper lip but not reach the vermilion line. And Class 3, when it cannot touch the upper lip. This was Kahn's results in terms of the upper lip bite test, comparing it with Mallampati. And this was a follow-up study by Ebhardt evaluating the upper lip bite test. Not quite as good as the person who described the test. Now, Dr. Shiga has written this extensive review and meta-analysis of screening tests for predicting difficult airways in otherwise normal patients. And as you see here, each test have a poor or moderate sensitivity and a moderate to fair specificity, and suggests that the most useful bedside tests are found in combinations of the Mallampati and thyromental distance. He also discussed combination tests, which we will talk about in a few moments, and I have added supplemental slides from this paper on my wiki. So what about obesity? Is that a risk factor? And the data are conflicting. It would appear that when controlled by for other factors, it may not be an independent risk factor. On the other hand, neck circumference more than 43 centimeters has been suggested to be more reliable than obesity per se. And again, I've expanded this discussion on the supplemental slides on Wiki. Now, we mentioned single predictors weren't too good. How about combined predictors? And these are a list of the various combinations that have been investigated. Unfortunately, as summarized in this review article, again, I've provided supplemental slides in Wiki, few of these combined predictors have been tested prospectively, and none have provided satisfactory results in terms of sensitivity and specificity. And none have investigated special populations. One simple risk score was suggested by Ebert, and you see that as you have more and more risk factors, the incidence of difficult intubation increases. But again, a very imperfect test. This is a summary of the recommendations about airway evaluation in this aforementioned review article. The bottom line is reliable predictors of difficult intubation remains unsolved problem and is likely to remain a decision based on clinical judgment. Finally, the practitioner should always be prepared by having difficult airway cart available and practicing difficult airway drills as well as special techniques because we aren't good at predicting ahead of time when we might confront difficult airway despite a detailed preoperative evaluation. There can also be failure of video laryngoscope, and this was summarized in this study by Aziz. We tend to think the glide scope is the answer to all difficult airways, but there are times in which it is unsuccessful. Now, newer scopes with smaller blades and different angulations may improve upon this, but it's important to recognize that no instrument is going to solve every problem, and thus you have to have all of these various assets in your armamentarium. Finally, the combination of difficult mask ventilation and difficult laryngoscopy. This is a multi-center study and found that difficult mask ventilation in about 2%, difficult laryngoscopy in about 4%, and difficult with both of about 4 in 1,000. These are they then developed a predictive algorithm for this problem, and this shows how successful it was in predicting the problem. Now, something that is probably underutilized but needs your consideration and I think application is the usefulness of a pre-op fiberoptic laryngoscopy. This was nicely proposed by Rosenblatt in this article in Anesthesia and Analgesia. And what they recommended was, prior to going to the OR, numbing the nares and putting a pediatric or infant fiberoptic bronchoscope down through the nose and thoroughly evaluating the airway before deciding how to approach. And they found by using what they call PAE, Preoperative Endoscopic Airway Examination, that this changed their plan in about a quarter of patients. So our last ditch, of course, is a surgical airway, but again, this doesn't always work. And so one must consider predictors of difficult surgical airway, and this so-called short list is one that one should consider. If they have a disrupted airway, if they have a hematoma or infection, if they're obese, if they've had previous radiation, and if they have tumors. Finally, there are also anticipating the risk of complications, extubation. I joke that it's easy to extubate. There's no problem extubating any patient. The problem, of course, is whether they can tolerate being extubated. And this list from Barash summarizes some of the risk factors for difficult problems after extubation, which one must always consider before planning extubation. Lastly, we need to emphasize that there is increased risk outside of the operating room, in the ICU, on the wards, in the emergency room, and in the pre-hospital environment. These have nicely been reviewed by 2 papers from Great Britain, which are also listed in your supplemental slides on Wiki. Finally, remember, our objective is to maintain oxygenation, not intubation. The aim should be avoid hypoxia, not to intubate. Therefore, both of these can often be alleviated by a supraglottic airway. And the early use of supraglottic airway should be considered before pursuing other approaches at intubation. In summary, the ability to manage the airway is a key characteristic of anesthesiologists. Difficulties with establishing an airway is a major cause of adverse outcome. Difficulties may be anticipated through a thorough history and physical examination, but unfortunately, no parameters or combined parameters have a perfect predictive ability. Therefore, one must always be prepared to manage any of these difficulties, ranging from the inability to ventilate with a mask to cannot intubate, cannot ventilate. Predicting a difficult direct laryngoscopy remains a large part an enigma. Commonly used indices may not only be less predictive than originally thought, but may be misleading. The advent of the video laryngoscope may make these deficits irrelevant, and new criteria need to be explored. I'm frankly a little bit skeptical that the video laryngoscope is going to eliminate all of our problems, and I think total reliance on that as the escape valve is potentially very dangerous. Thank you.